I don't know if anybody has a question. Please come to the microphone. What we heard in the second session were a variety of new procedures or procedures that are being done now, from renal denervation to transcarotid, cervical carotid intervention to venous flow reversal, and then the tools in the tool chest. I guess I'll see if anyone has any questions. If not, I'll start off by saying, you know, I think maybe the greatest innovation, as you highlighted for us, Kintur, was the access points and the ability to go to different parts of the body. I mean, I think fundamentally there's a lot of tools, but that would be one. And somebody has a question there, I see, so let's see what you're...
Are you doing the...
Yeah, go ahead. We'll ask him to turn it on.
Are you doing the supply chain talk next?
Yeah, we're going to do a supply chain now, too, and happy to answer supply chain questions, too, about
Okay,
that.
I'll come back.
Well, you can ask. Go ahead and ask. Yeah, we'll do it.
I just wanted to say, actually make a comment more. Please include your managers in conversations when you guys are looking at new technology. I have a new, well, not new anymore, physician. And sometimes I would get hit with these questions from supply chain, and they're wanting to change things over. But I don't know that they're talking to the physicians yet. So please include your managers so that they can be your advocates. That's all I just wanted to make sure.
That's a great point, and this is part of supply chain. So with the new technology comes a supply chain question. I can tell you that most common email I get is from our cath lab supply chain manager, who's been approached by 7 different doctors for 7 different devices for the same indication. And so one of the things I guess maybe we should talk about with the ultrasound or other activities is, what do you all have in place to try to, you want to innovate, yet you have to control, let's say, some of the costs, or at least understand how many different wires does one need. So how do you all manage that?
So I could start on the far side of the spectrum. So our facility is actually an Ascension healthcare facility. Yeah. And so across Ascension, which is 153 centers nationally, there's actually a large organized GPO, or group purchasing organization. So the contracting process is actually done across the entire nation. And so there's actually a very quite well organized cardiovascular service line with separate entities, from interventional coronary through peripheral vascular affinity through electrophysiology. And the decision-making process attempts to take kind of leaders from the different territories or regions and make organized decisions about what's going to be brought onto shelves across the country. Now, there's strengths and benefits to that. You know, we get the best price on an Abbott science stent in the world. The problem is it sometimes takes a long time to get new innovation on without running it up the correct flow. So that's probably one far side of the spectrum from organization.
So for us, it's kind of a little bit easy because we are just a small heart and lung hospital only, and that's all we do, cardiovascular medicine. But I can tell you the perspective is that we need to have a fine balance. There's one thing about, you know, managing the inventory and the cost. But when it comes to the decision making, I think we should definitely stand up for physicians' participation. I don't know, for the places which are bigger with the GPO making the decisions, I don't know how much is the physician involvement. But I think going forward, that would be one very important thing, that the physician perspective should always be there on the table in decision making, and which are the tools that you are bringing in the lab. And of course, you discuss all the evidence-based as well as comfort of use and overall clinical outcome, along with only the cost issues should not be the only driving factor.
I was just going to say that it's, you know, when a new technology wants to be brought in, you have to do some research and look at your own internal volume and how much do you think that device is actually going to be used, and is it really unique or better than what you currently have? I work at both Duke and the VA, and at the VA it's a much smaller shop, and we have to be careful about shelf space and those sort of things. So a lot of things play into that.
I don't know if there are any other comments. I'm happy to see if there are other comments by anyone. Gary's probably thought about this a lot, and so I know you've thought about this.
So I'll probably try to touch on this during my lecture more, but I think one of the take-home points will be, if you just focus on costs, you'll either be purchased or you'll be closed, because the new future is not upfront costs. It's going to be a treatment time effect. You know, it's an interval time. It's how long that patient's going to stay out of the healthcare system and for how long. So you have to look at that perspective. You just can't look at upfront costs.
Absolutely, it has to be a total look. And maybe we'll just, in the interest of time, keep going here and go on to our next talk, which I think, Gary, I think you're giving us a talk on supply chain and ways to innovate in that space, approaches to reduce costs. I think we've, let's see, what's showing on our screen is not what's showing on the big screen. Maybe if you could launch Dr. Ansell's talk. Let me see if I'll go back here and see if I can.
Being the old guy, I brought my slide deck earlier, put in the carousel.
Is that possible for you in the back to change the screen up here?
It's locked up a couple times, best laid plans, right? Let's see what we can do here. I'm going to see if I can.
So in the meantime, let me ask Vic, how do you decide exactly the access point for the transcarotid access?
That's a very good question. So there's some technical details. Not every patient is eligible for TCAR. They need to have at least a 5-centimeter runway of common carotid artery from the access point to the bifurcation or to the lesion if it's in the distal common carotid artery. You need a common carotid artery that's free of disease. There are some patients with really tremendous atherosclerosis that'll have calcified common carotid arteries, and those are not good patients to do TCAR on. They have to be normal, essentially, common carotid arteries just above the clavicle. On the right side, it's fairly straightforward. It's only about 2 centimeters beneath the skin. You go in an avascular plane between the two heads of the sternocleidomastoid, and it's pretty apparent. The left side can be a little bit deeper, a little bit more challenging, but again, as long as you have enough of a runway, the intervention itself can be done. There are other technical issues related to the procedure I won't go into, but in general, once a individual has done about 5 or so cases, it's actually pretty straightforward.